Hi, good evening, and welcome to Health is Skin Deep, our virtual observation of Black History Month 2021. Please help me welcome our esteemed panelists, Ms. Lily Tyson Head, Dr. Arvilla Payne Jackson, Dr. Rosanna Barrett, Dr. Joel Ebo, nurse practitioner Yashika Roy, and Dr. Ali Osman. Tonight, they will guide us through the Black community's challenges, contributions, and lasting legacy with healthcare in the United States. Our program consists of 3 segments. In the first segment, Owning Our Legacy, we will acknowledge the lives of the 623 men who were victimized by the syphilis study that took place in Tuskegee and Macon, Alabama for 40 years, from 1932 to 1972. And we will honor their legacy and contributions to healthcare. In our second segment, we will address the importance of our roles as patients, participants, clinical investigators, and providers in building diversity and inclusion in every aspect of healthcare. Our theme for that segment is Not for Us, Without Us. Finally, our primary care and emergency department providers will discuss bridging the gap between trust and distrust by providing comprehensive assessments and decreasing missed opportunities for patient care in the emergency department and the primary care settings. In order to enhance the enrichment of this discussion, you are encouraged to participate in the one answer survey question at the beginning of each segment. And please type your questions for our presenters into the chat box. Your questions will be shared with the appropriate presenter at the end of each segment. A special thank you to our staff, volunteer and supporters, Baptist Hospitals of Southeast Texas, 310 Events, American Association of Nurses in AIDS Care, Achieving Together, Voices for Our Father's Legacy, Jessica Nava, and Amani Hamad. I am Cordella Lyon, your organizer and moderator for this evening's event. Please sit back, lean in, and listen as we look at healthcare in the Black community from 1932 to 2021. Our first question for our first survey question for this segment is, would you participate in a clinical trial? While you're answering your survey question, I'll introduce our panelists for this first segment, Owning Our Legacy. Mrs. Lily J. Tyson Head is the daughter of Freddie Lee Tyson, one of the 623 men in the United States who were in the United States Public Health Service syphilis study performed in Tuskegee and Macon County, Alabama in 1932 to 1972, and the daughter of Johnny May Neal Tyson. Mrs. Head is embedded in her love of God, faith, and family. She's passionate about social justice and treating everyone with kindness and respect, especially those who are in most need. Mrs. Head and her husband, Wilbert, are living their retirement years in Wirtz, Virginia. She is the mother of sons Will, Mark, and wife Tanika, and daughter Carmen, and the granddaughter of twins Bryce and Kylie and Trinity. Mrs. Head is the chair of Voices for Our Father's Legacy Foundation, an organization formed by the descendants in 2014 to remember, celebrate, and honor the 623 men that were victims in the USPHS syphilis study. She enjoys being active in different ministries at her church, traveling and volunteering at Booker T. Washington's National Monument, the birthplace of Booker T. Washington, where she is the founding president of Friends of Booker T. Washington. Mrs. Head is humbled by her yearly mission, visiting the children at 2 orphanages in Port-au-Prince, Haiti, with members of her church. The time that she cherishes the most is the time she spends with her 3 grandchildren and children. Mrs. Head retired as a physical education and health teacher after 31 years from Waterbury, Connecticut public school system. During her professional tenure, she was a coach, mentor, and advisor for her students and colleagues. She started her own educational consultant business in 1998 and worked for Waterbury Public School System, Area Cooperative Educational Services, and Capital Region Educational Council. She is a Tuskegee Institute graduate with a Bachelor of Science degree. She received her Master of Science from Southern Connecticut State University and her Education and Administrative Leadership graduate degree from the University of Bridgeport. Mrs. Head has received numerous professional and civic awards recognizing her leadership, educational initiatives, program management, and devoted service to the Waterbury community. Welcome, Miss Lily. Her co-speaker is Dr. Arvilla Payne Jackson. Dr. Arvilla Payne, PhD, received her doctorate from the University of Pennsylvania. She has taught medical and cultural anthropology and linguistics at Howard University for 45 years. Her publications include books and articles on traditional medical systems, African American oral history projects, sociolinguistics, and service learning. She has conducted ethnographic evaluations for federal, state, and nonprofit organizations, projects, programs on drug abuse, HIV/AIDS, ex-offender re-entry, domestic violence, gun violence, and youth violence, among others. She was a visiting scholar in folk medicine at the University of the West Indies, Jamaica, and is currently a visiting scholar at the National Center for Bioethics in Research and Healthcare. She's a consultant with the Voices for Our Father's Legacy Foundation and is doing research for a book on the untold stories of the men who were victims of the USPHS syphilis study in Tuskegee and Macon County, Alabama, and their descendants. Welcome, ladies.
Good evening. It is my pleasure to be a part of this important conversation on behalf of the Voices for Our Father's Legacy Foundation. In 1999, descendants gathered proudly to commemorate the 1997 National Presidential Apology at the grand opening of the National Center for Bioethics in Research and Healthcare at Tuskegee University. After several years of commemorating the National Presidential Apology for the Public Health Service syphilis study, descendants felt that there was more that must be done in order to move from the trauma. The National Center has sponsored this event for descendants annually since 1999. The descendants realized after several years of meeting together that we still shared haunting, painful feelings of anger, frustration, and humiliations. And it was time for us to do more than to just meet and lament. After several years of participating in healing sessions guided by Dr. Edward and Dr. Ann Emberly of the International Theological Center, we accepted the call to honor our ancestors' sacrifices and their legacies. Their untold stories, as well as the stories of their mothers, families, and their communities. They are all left out of the history about the study. Therefore, a full and true story of the public health study and all of its unknowns must be found and revealed. The 623 African American men in the study were treated as subhuman, unresponsive to pain, and less worthy of receiving proper ethical and equitable medical treatment. The foundation was organized by descendants in 2014 as a 501c3 nonprofit organization at Tuskegee University. We decided to begin the journey of remembrance, reflecting, and honoring. The foundation's mission is to preserve the legacies and the history of these trusting souls who were victims in the study. We are fostering social justice, providing outreach fact-based events, and awarding annually higher education scholarships for descendants pursuing an education in all areas of health-related services, public health, and biomedical research. We are building a lasting memorial and inspiration garden at the Bioethics Center that will preserve history and provide a space for honor, for reflection, and healing. No longer should our fathers be defined only as poor, helpless victims that were used as guinea pigs in the Public Health Service study. They were human beings and worthy of being treated with the care, the dignity, and respect every child of God deserves. All of these beloved men were someone's sons, husbands, brothers, fathers, grandfathers, uncles, cousins, friends, and neighbors. They lived and survived during some of the most racially charged injustice times for African Americans in this country. Their stories are extraordinary. They were head of households, providers, ministers, and pillars in their communities. They were farmers, masons, deacons, and men of many talents. We are all a part of their legacy, and it is our responsibility to continue to seek accessible medical treatment for all that ails us. Each of us should expect and receive the best possible health care available, regardless of our skin color, our socioeconomic status, and the level of our education. Excuse me. As a result of the longest lasting biomedical and non-therapeutic research study in the history of our country, the National Research Act was signed into law in 1974, creating the National Commission for Protection of Human Subjects of Biomedical and Behavioral Research. The Institutional Review Board was created to protect the rights and safety of human subjects who participated in research studies. Informed consent became the fundamental law of the fundamental in both law and ethics, and the study today can become the catalyst that changes the dynamics in addressing medical racism, health disparities, and health insurance, a legacy that was left by their sacrifices. The maltreatment in health care due to racial and social injustices over centuries have contributed to the erosion of trust within the Black communities. There are two old sayings that matters most to me, especially now. One, that action speaks louder than words. And two, seeing is believing. I feel before we can build trust in healthcare, there must be changes in attitudes, skills, and opportunities. They must be in place in order to lead to trustworthiness that will foster trust. There are 10 things that I feel are vital in coming to this point, and they are respect, trustfulness, equity in care and accessibility, competent and skillful in practice, transparency and sharing data, education and information campaigns, patience, empathy, compassion, diversity and inclusiveness, and availability and affordability of service, and indeed, faith. It is disheartening to know the devastation the COVID-19 is having on the world today, especially in our local Black and Brown communities. I pray that everyone who are physically able to get vaccinated do so after consulting with their healthcare providers or someone whom they trust. There are many who still believe today that the men were injected with the syphilis virus. That is not the case. They were not. They did not have the information that we have today, neither the resources that exist now. They were denied the penicillin vaccine to cure them then. And we shouldn't, I believe, deny ourselves the COVID vaccine now to cure us. I urge anyone hesitating because of the United States Public Health Service study, commonly known as the Tuskegee Syphilis Study, as their reason for hesitating or not taking the vaccine. Please do not consider this study as your reason. Make your decisions on the facts, listen to the scientists, healthcare providers, and the people that are around you and you believe in them. Become informed. Get all of the information that you can. And if you are physically able and willing then to get the vaccine to protect yourself, your family, your neighbors, and your fellow man. On February the 8th, my husband and I took our first Moderna vaccine. We are scheduled to get our second shot on March 9th. I could not wait to get vaccinated. It was a bit disappointing and discouraging and frustrating trying to get registered and to get an appointment. And this seems to be be a lingering problem as well. It is also seems to be a problem of short supplies of vaccines in area where it is needed the most. And locations in some places are not as convenient as they could be or should be. Recent reports, though, suggest that things might be getting better. Leaders in the community can be a powerful influence during this time. They have gained the respect of their people. They also have proven to be noteworthy, honest, truthful, and of desirable character. Leaders of the religious community are also trustworthy and can also strengthen faith. In addition to having trust, I think we should always have a leap of faith. The active participation of our leaders in this effort are both significant as well as vital. Healthcare workers, teachers, public servants, leaders of organizations are too part of the community leadership team. Sister to sister, brother to brother, friend to friend, neighbor to neighbor can also play an important part in helping to bring this pandemic to an end. I'd like to close by offering my prayers and deepest sympathy to everyone who have lost a loved one during these times of sorrow and sadness. Thank you for the pleasure.
Dr. Arvilla Payne Jackson, she is sharing this segment with Miss Lily. She will tell us more about her research with the victims of the syphilis study.
Good evening. It is a pleasure to be here with you this evening and to share with you some of the results we've had from the interviews we have done with some of the descendants. I have talked with 38 descendants, ranging from children to great-great-great-grandchildren. And the quotes that I use tonight are coming from those interviews. One of the first things that I want to talk about is distrust and the consequences. Distrust of the federal, the state, and local governments, the medical system, and higher institutions is a major consequence of the study. The men trusted the doctors as they represented the federal government and believed that it was reaching out to help them. As one daughter said, the men never questioned the doctors because of who they were and their social standing in the community. They trusted the doctors and the nurse and believed that those with education were honorable, honest, and would morally do right. The betrayal has had a serious negative impact on the descendants. One granddaughter said it this way: "I don't know what effects the study has had in general, but my dad does not like doctors. He has to be dying before going. He doesn't trust them. There is also a general distrust of higher institutions. What were the ulterior motives behind what they offer? Distrust is deep. For example, it has recently come to the attention of the Voices for Our Fathers Legacy Foundation that specimens taken from the men's bodies at autopsy have been used in the past in experiments. They were stored at the National Institutes of Health. A recent inquiry by the Voices of Our Fathers Legacy Foundation using the Freedom of Information Act as to the location of the specimens has not been answered. Descendants still struggle with bringing those responsible to the study to accountability. Their questions include, why was there no accountability on the part of the United States Public Health Service? Why were the doctors not held accountable for what they did? Why were the local, state, and federal institutions not held accountable, including the CDC, when it agreed to continue the study in 1968 when they came on board? One grandson, who was raised by his grandfather, said, "We were shocked and disgusted when we found out about the study. How could doctors do nothing to help these men? How could they give no medicine? All they wanted to do was to see what effect the syphilis had on the men's organs. The doctors already knew the answers. If you put acid on a person's hand, are you going to stand around and watch it eat the flesh away? Why weren't the doctors called out? Why did they get a free pass? They knew what they were doing wrong, just seeing how many people they could kill. They only stopped because they were caught. How did the members of the doctors' families feel about what they did? They need to apologize for what the doctors did, but you don't hear from them. Why not?" And a great-great-granddaughter says, "The U.S. government has never been held accountable for what it did. The apology was a long time coming, 25 years. The agencies responsible need to reach out to the families and all the descendants and find out what their needs are. The descendants have and are still experiencing trauma, and that's one thing that has not been addressed. The nature of the role of Tuskegee Institute, now Tuskegee University, played in the study is still unclear. Some of the unanswered questions that descendants have asked is, how much did the Institute's personnel know about what was going on? Why has it not been held in full accountability for its part as well? One great-great-great-granddaughter said, "I have always had pride in Tuskegee University, its happenings, and the powerful people who have been here and changed history. The university is a place of professionals and intellectuals who are supposed to support African American growth. The university had responsibility for the men. What did they know? Someone had to know what was going on. Even at the hearings, there was no accountability." While distrust runs deep in the blood among the descendants, some suggest research is important. One grandson noted, "It is important to not be afraid of research and testing, to find out how things work. We don't have to abuse human beings to achieve ends. Research is necessary to discover answers to things we can be better off, so things can be better off. Be curious, find out about things. We need to will our bodies to science. We may have properties that others may not have that can be used to help others, as with Miss Henrietta Lack. Don't be afraid of knowledge. Don't be afraid to tell the truth about your family. Research and find out what is going on now and what went on then. As Rosa Parks said, we need to know common sense things." Two underlying issues in the healing process for families are trust and trustworthiness. Miss Lily has talked to this. Because of the profound sense of betrayal by the U.S. government, the rebuilding process requires demonstrable measures of trustworthiness before trust by the descendant family members can be expected. The great cause of mistrust was the pain and hurt from the betrayal. The feeling of distrust spread faster than any other feeling. Families are seeking the truth in their quest to establish moral authority, which was clearly abdicated at all levels of the study. Trust itself is characterized by belief, hope, faith, reliance, and confidence in the administering institution. One daughter noted the trust violations for families is that we know much of what has been said about the study is not true. but we do not yet know the complete truth. Efforts by government institutions at all levels since the end of the study are still questioned as to their trustworthiness. Do they demonstrate honesty, fidelity, dependability, reliability, and credibility? Before trust can be rebuilt, trustworthiness must be established. And there are several basic elements that are needed to build trustworthiness. First is showing respect. Second is committing time. Third is saying what is being done. Fourth is doing what is claimed you're going to do. 5 is giving back to the community. And 6 is believing and knowing that families know the best thing to do. The ongoing partnership between the Voices for Our Fathers Legacy Foundation, the National Center for Bioethics and Research in Healthcare, the individual family members, and the community provides a model for building trustworthiness for communities that have suffered trauma. The descendants have chosen not to live in anger and bitterness, but to change the narrative from trauma to healing and shame to honor. The families honor the legacy of the sacrifice of the men. The legacy of the United States Public Health Service syphilis study has 2 parts, the known legacy and the hidden legacy. The known legacy resulted from the exposure of the study in 1972 and the subsequent public and congressional inquiries into the study. The hidden legacy is related to the untold story of how the blood sera of the men was used by the U.S. Public Health Service to establish national and international hegemony on the research to develop diagnostic tests and treatments for syphilis. On the screen, I'm not sure if we can enlarge it. Yeah. The known legacy was, as Ms. Lilly noted, the National Research Act that took place in 1974, the establishment of national review boards. All research has to go through the institutional review boards to make sure that both humans and animals will not be harmed. Then the institution of informed consent. You have to let people know what you're doing and what the outcome is going to be, and the procedures, medications, et cetera, that are going to be used. The Belmont Report in 1979 resulted in the establishment of the Office for Human Research Protection. Federal laws and regulations requiring the institutional review boards were part of that study. The multidisciplinary symposium that took place in Virginia in 1994, President Clinton was advised to apologize for past government wrongdoing related to the study. 4 years later, in 1997, President Clinton finally made the apology. The National Center for Bioethics and Research in Healthcare at Tuskegee University was established in 1999. The goals were to prevent any reoccurrence of unethical research and continue to honor the legacy of the men and families affected by the study, to address the tremendous sacrifice they made toward improving human subject research and healthcare delivery. The last one that I'm going to mention on the known legacy was the establishment of the Legacy Museum at Tuskegee University, which was established in 2009 and includes exhibits on Henrietta Lack and the victims of the Public Health Service syphilis study. Now, one part that isn't well known was presented in an article by Dr. Benjamin Roy in 1995. The title of the study was The Tuskegee Syphilis Experiment, Biotechnology, and the Administrative State. This was put out in the Journal of National Medical Association. And one thing we never hear about is the fact that the blood sera from the men was used by the Public Health Service to, as I said before, develop this hegemony on research and testing. In 1949, the blood sera was used to establish the TPI test. In the 1950s, there were collaborative studies that used the Tuskegee sera, and the sera was stored in the Venereal Disease Research Lab of the United States Public Health Service. 1956 to 1957, the new Serology Evaluation Research Assembly used the Tuskegee sera for a serodiagnostic survey. In 1956 to 1957 also, the Tuskegee sera was used for the Reiter protein complement fixation and treponema complement fixation test. Tuskegee sera was used to test what's called the FTIC test for Tuskegee. And Tuskegee sera was used to develop the most important diagnostic test since the TPI. This was called the FTA-ABS. This test was important because it could distinguish false positive serology from true syphilis. The Public Health Service acknowledged that the development and our endorsement of the FTA-ABS test rested on the Tuskegee sera. That test was commercialized and it replaced the TPI test. The World Health Organization globalized the FTA and the FTA-ABS test. They became the international market for syphilis serology. Tuskegee sera was also most likely the source of control sera, distributed to state and private laboratories in the United States and through the World Health Organization to laboratories throughout the world. The experiment, the Public Health Service study, had 423 men in the latent syphilis group and then 200 men in the control group. So the sera from both groups has been used in the testing. Other nations were dependent on the Public Health Service for standardization and application of U.S. tests, and the Venereal Disease Research Lab slide test and the FTA-ABS test. Those are all very technical. That's why I gave you the reference to Dr. Roy, his article, because you will get a much clearer understanding of the hidden legacy of the men. In conclusion, descendants want to make sure that no one ever again suffers the abuse the men suffered at the hands of the government and doctors. They want it known that the impact of the study did not die with the men, but extends for generations. To achieve their goals, the descendants want to tell their stories in a book and continue their search for answers to their unanswered questions. As one great-granddaughter put it, we won't have peace of mind until we know what really happened. And the way to make sure this doesn't happen again is not to let the study be forgotten. The study should be presented without animosity. And thank you for letting me participate in this evening.
Thank you, Dr. Jackson. We have a question for you. Deborah would like to know, how was the truth found out about the experiments?
There was Peter Buxton was working with the Public Health Service in California, and he came across it, and he leaked the story to Gene Keller, who then put it into the public purview. And that was, I think it was in 1972, July of 1972. And then once the news hit the paper, then it became a national situation.
Thank you. Ms. Lilly, how can descendants get in touch with you regarding participating in building the legacy, or if you're working on any issues, any programs with genealogy?
No, we are not at this time, but that can be a part of our research and networking in the future. But no one at this time has reached out to us, nor have we reached out to them for that. We have, though, visited and searched records at the CDC in Morrow, Georgia, to find out more information about the medical records of the men, and we plan to continue that.
Thank you. And there is another question for Dr. Jackson. In reference to some similarities between the serum of the men who were in the syphilis study and Henrietta Lacks being used for future studies, are there any differences in how both experiments took place?
Yeah, from my understanding, what they were trying to do with the public health service study was simply to follow the men to their death so they could harvest their organs to see the impact of syphilis on their bodies. However, they already knew the answers to what the impact was before the study even started, which is what makes this study even more egregious. But with Henrietta Lack, that was, based on an individual, and it was looking at, her genetics. So two very different studies in terms of what they were trying to do.
Thank you. Are there any other questions for our panelists? Okay, thank you, ladies. And for the poll, we had 60% of people agreeing that they will take the COVID vaccine. 60% agreeing that they would participate in a clinical trial, and 40% saying that they would not participate in a clinical trial. Up next, we have our journey continues as we bring forth Miss Dr. Rosanna Barrett. Here we will talk about the disparities in healthcare as it relates to Blacks, and I'll introduce Dr. Barrett. Dr. Rosanna Barrett is a public health professional with more than 16 years experience administering public health and human services programs. She earned both master's and doctoral degrees in public health, specializing in epidemiology and biostatistics with electives in public administration. Throughout her career, Dr. Barrett directed several state and federally funded community-based programs aimed at improving the health and well-being of vulnerable population groups. For 5 years, 2013 to 2018, Dr. Barrett served as the director for Texas Office of Minority Health and Health Equity, promoting policy and practice change to improve program and service delivery and to ensure optimal health for all. Dr. Barrett is passionate, collaborative, and committed in her approach to addressing health and healthcare disparities. She has championed efforts to eliminate chronic disease and maternal and infant health disparities. Throughout her professional journey, she has served on numerous committees and workshops such as South Regional Health Equity Council, March of Dimes, Steering Committee for African American Outreach, and the University of Texas Black Mamas Community Collective. She continues to provide consultation and support to advance health equity and with a strong focus on health and healthcare transformations. Please help me welcome Dr. Barrett.
Good afternoon, everyone, and thank you for having me. Thanks for that really elaborate introduction, Ardella. Pleased to be part of this panel and to speak to the topic of health disparities. In dovetailing from what our first two speakers mentioned about, we already have some kind of insight as to the disparities that Black and Brown people face in America. One of the questions I was asked to talk about is the difference in health disparities in depending on whether you're living in a rural area. So I'll just focus on some of the impact of rurality and healthcare disparities. First, I'll start with what is considered rural, and because that geographical area might change depending on who you're talking to and the different places that you're considering. The United States U.S. Census Bureau described rural as what is not urban, which can be interpreted as any area that are not included in as urban population and territory outside of cities and towns with about 2,500 or more people are usually considered rural. These areas are usually sparsely populated and are distances from some essential services such as healthcare. And this definition might evolve over time, and it might be different for different federal and local agency and researchers in terms of the population that they're investigating. Some mid-sized cities, as we've seen, and small towns have grown into larger urban areas over time. According to the CDC, rural America faced numerous health disparities compared to their urban counterpart. More than 46 million Americans, which is about 15% of the US population, live in rural areas, which face distinct challenges, especially during the COVID-19 pandemic. Rural Americans experience disparities because of risk factors such as I said, geographic isolation, lower socioeconomic status, higher rates of health risk behavior, limited access to healthcare specialists and subspecialists, and limited job opportunities. This inequity in some way that rural resident faces, that a rural resident faces because they are less likely to have employer-based health insurance coverage. And sometimes they do not meet the federal poverty level cutoff in terms of income cutoff for Medicaid. And of course, we see some of the risky behaviors, even though they challenge it with social determinants of health, also put rural Americans at greater risk. They usually have high blood pressure and high obesity rates, and they're more or less likely to have what we call leisure time in urban areas and less likely to wear seatbelt as compared to their urban counterpart. They also have higher rates of poverty, as I said before, less access to healthcare, and less likely to have health insurance. And we have seen that, especially rural Americans in southern states, they have higher mortality rates, which may vary by race and ethnicity. For example, from 2012 to 2015, rural non-Hispanic Black adults are more likely to report having multiple chronic health conditions than non-Hispanic whites, and more likely to be at risk for obesity and severe obesity, as mentioned before. They are also more likely to die from heart disease, cancer, unintentional injury, chronic lower respiratory disease, and stroke than their urban counterparts. Rural areas are more likely to have challenges in terms of distancing from health and public health care services. They have longer distance to travel for care, and most time the services such as specialty and emergency care are not available within their immediate vicinity. That means they'd have to travel to get this type of care. So usually some rural areas are dubbed as healthcare deserts, and residents are usually categorized as experiencing what they call distant decay, where service use decreases with increased distance. So in essence, lack of sophisticated care or high-intensity healthcare and services will further worsen their condition. And you can just imagine during our COVID-19 period, the pandemic, just in seeking care can be really challenging for rural residents. They are also living in what we call the digital divide in terms of less access to high-speed broadband and mobile phone network, which increase that digital gap between urban and rural areas. And this is more serious when you're trying to get care and when you're searching for job opportunities. And that's one of the biggest challenge that would be in terms of accessing COVID testing centers and also getting access to the vaccine. We did mention about other diseases, but I just want to point out, because since the Cordelia's group really look at HIV and AIDS, that African Americans are more likely to have high proportion of new HIV/AIDS diagnoses compared to other races and ethnicity. And in 2018, it was reported by CDC that although Blacks account for about 13% of the US population, about 42% of the number of cases include Blacks for new HIV diagnosis. So there is that delayed HIV care initiation that might lead to greater morbidity and mortality and further HIV transmission among African Americans. So what are some of the lessons we learned from the high mortality rate of COVID in the Black community? What we have seen is that it's no different from all these other diseases that I've mentioned. racial and ethnic minorities, which include African American, Hispanic, Latinos, American Indians, and Alaskan Natives, and Asian and Pacific Islander, which is now being called BIPOC, as the Black and Indigenous and other people of color, that increased risk of getting COVID-19 and have severe illness because of long-standing systemic health and social inequities that have placed them at increased risk. We have seen, for example, that because of some of they meet the high-risk categories because some of the chronic disease that they are diagnosed and actually living with. Well, we have seen also that there's challenging because of lack of health insurance and language barrier to accessing COVID-19 information so that they can be informed before even considering taking the vaccine. According to surveys, many Americans, including African Americans, are willing to get vaccinated, as we've seen, but because of the mistrust that the two first presenters talk about, they're more reluctant to getting this vaccine with lack of information about the side effects and the impact that it will have long-term on their health. And unless the American healthcare system really undergo a paradigm shift to end racial injustice in healthcare, access to COVID-19 vaccine will be further delayed for treatment of disease, especially among Black and Brown people. We definitely have to tackle those deep-seated systemic issues related to bias, access to care and education before we can see that health disparity declining for COVID as well as for other chronic disease that Black and Brown Americans are facing. According to a recent study done by Kaiser, many of the barriers to vaccination are rooted in this historical legacy of abuse and mistreatment by the medical system, as mentioned by my colleagues, and ongoing racial discrimination. There have been reported that Black Americans in many communities got turned away when they present themselves to the hospital with COVID-19 symptoms. They often don't get the test that they asked for, and even when they might be having COVID-19 symptoms, such as high fever or struggling to breathe. You may have heard of the tragic experience of Dr. Susan Moore, a University of Michigan educated physician who recorded videos of her fight with COVID-19, where she documented the second-class treatment she received for her illness. Even though she was a physician, she could not advocate for her own treatment and the respect she deserved as a patient. Her pain was downplayed, even though she begged for that compassion care from her colleagues, only to be sent home prematurely and ultimately died from COVID-19 related complications. So what lessons have we learned based from just the disparities that we see in Black and Brown communities in terms of chronic disease and COVID-19, and how can we build a more equitable healthcare system? We're going to see, unfortunately, that Black communities are going to have these conditions continue, but we are being hopeful that this will change as we shine light on these inequities and really expose the inadequacies in our healthcare system. So first of all, we have to address the social determinants of health, such as economic instability, lack of poor education, food insecurity, transportation issues, and poverty, to better reach the diverse population that we serve through healthcare. And healthcare professionals and hospitals should see the link with social determinants of health and healthcare, as they greatly influence the health of patients. Another thing, strategy could be ensuring affordable healthcare and expanding healthcare services by limiting the cost of premiums and out-of-pocket costs, providing equal access to quality care and treatment. As we've seen with the Affordable Care Act, which has helped to ensure healthcare coverage for millions of Americans, that the uninsured rates among African Americans did decline after the law was implemented. But we still see that there's still a gap between white and African American in terms of the coverage rates in America. We see that, for example, in 2018, the uninsured rate among African Americans were about 9.7%, and that whites was about 5.4%. African Americans are more likely to be covered through employer sponsored or private health insurance rather than, and sometimes do not meet the income requirement, as I said before, for Medicaid. Another strategy is having healthcare systems that are more diverse in their leadership, racially and ethnically diverse in leadership and among providers. While we can see about, I think a survey was done that 82% of white patients say their doctors look like them, but only about a quarter of Black and Latino patients say their doctors share their race and ethnicity. But despite popular belief, studies have shown that minority physicians, Black and brown physicians, are more often and likely to go back to their communities to help vulnerable patients. Providing culturally congruent healthcare and breaking down that cultural barrier will decrease morbidity and mortality rates for people of color. Providing patient-centered care to meet the diverse needs of patients, where providing care that is respectful and responsive to the individual patient preferences, needs, and values, and ensuring that patient values guide clinical decisions. Not only do patients benefit from this strategy, but providers and healthcare system benefits as well to improve satisfaction score among patients and their family, enhance the reputation of providers among healthcare consumers, better morale and productivity among clinicians and auxiliary staff, improve resource allocation, reduce expenses, and increase financial margins to the continuum of care. One of the things we have found by just listening to the story, the videos that we talk about, that Dr. Susan Moore talked about, is debunking some of those myths about health and of racial and ethnic groups, including the unfounded absurdities such as Black can handle more pain and have thicker skin. Is really getting physicians to be mindful of how these stereotypical labels have put African American and also other people of color at risk for having more severe conditions because they are ignored when they actually talk about their healthcare health challenges or problems. So that's my presentation. I hope I was able to clarify some of the issues that were supposed to be discussed, and just open now for questions.
Thank you, Dr. Barrett. One of the questions I have is there a difference between stigma and discrimination?
So stigma is sometimes the source of discrimination in some ways, because if you're talking about the stigma related to the physician not willing to touch a Black patient, for example, a white physician might not want to provide care to a Black patient, that could be seen, but in terms of stigma. But if in terms of the person's not willing in seeking healthcare because of mistrust, then that also, and in some communities, certain diseases such as mental illness is still stigmatized. And so people are less reluctant to seek care because they don't want to be labeled as insane. And so, but I've seen over the years that through education and through culturally appropriate information being given to these communities, that have opened up the opportunities for people to seek care. And we can see that also with HIV/AIDS for Black men to admit that they are they may have same-sex relationship and to seek care early. But we're seeing the increase in screening among Blacks over the years in HIV, and we're seeing more diagnosis, not because Black men or Black women are having HIV more prevalently, but because there's an openness to have that screening being done within these communities.
Thank you. The second question I have, the listener asks, COVID and HIV are disproportionately affecting members of the Black community. What structural disparities can we eliminate to ensure that these communities receive equity in care?
Some of the structural, first of all, we will talk about rural versus urban, and that healthcare is not accessible to people in rural communities because of the distancing of facilities from where they live. So that is also a challenge I've seen in some interventions, public health interventions that, and healthcare interventions, that they use mobile clinics to get to these communities that don't have access to healthcare or improved transportation to get them to the point of care. And even the hours of opening healthcare clinics for them to access. There are also structural barriers in terms of where programs are administered, and sometimes there's administrative barriers in terms of access to care. And the geographic isolation can cause that, but we see even in urban areas where you have segregation, that access to care is also a limitation, that Black and Brown communities are placed in where there is poor quality healthcare being provided. So that could be considered as well, because you can have geographical disparities in terms of where healthcare services are available.
Thank you. And my question, we've talked about color as we, with disparities, and with the distribution of COVID vaccine, we find now that the elderly are being left out because they're facing the digital divide with registering. Would these something similar help the elderly to get enrolled for vaccines and to actually receive their vaccines with the mobile clinics and so on?
That's a possibility to explore that. I was looking even at the data and the maps of where the sites are to get COVID vaccine. They're not in low-income areas. So that's going to be a problem with transportation. So getting the vaccine to them in those areas. We have used in past experience when we trying to address health challenges is using navigators and what we call sometimes community health workers to get to these communities who are knowledgeable about the prevention strategy and can inform people about how to access this care. And even there are times when people were taken to the sites to get tested or even to get treatment. And so what we have been seeing is what we call COVID equity problems, is that people are lining up to get the vaccine as well that are not on the high-risk list. And we're asking that if you know an elderly person who's trying to get, who's having difficulty signing up and having challenges getting to the site, to volunteer your time and take them there and get them enrolled in for the vaccine, rather than trying to go in line and to get the vaccine yourself if you're not one of the high-risk patients.
Okay, so in reaching back, one of the things that was utilized during the syphilis study was that it was the community nurse who actually got the men to go to the facility for the study. There was somebody who they had built trust with that was working within the community. So probably similarly with helping the elderly and those who are disconnected from care services, that we could actually utilize the people on the ground, those culture brokers, so to speak, to build trust in getting people to access care.
And there was a lot of misconception around the Tuskegee study that people were not informed. And that's a bit, we have social media and so much now that we are really exposed to information much more readily than during when the study occurred. So people can also, I think we have young people in our community and in our homes and in our families that we can access information from the internet if we're not able to do so. And there's just this misconception that the study was being done to help people. Now so we are seeing a difference now that you have proficient and knowledgeable physicians and nurses that are from the Black community that can provide that information, and they can be trusted brokers to go there. We've seen the doula care have been really instrumental in helping in terms of maternal health care. So we have evolved in a lot of ways because we have much more representation in the healthcare, even though that there's still a lot to be done, that we can trust with the knowledge, and having that information can give you, allow you to be more informed about the type of care and to be more involved in your diagnosis and treatment.
Thank you. Joyce asks, what about the local churches for those folk in rural communities in helping people to get into care? I think that's what Joyce is alluding to.
I know the pastor I've used is pulpit a lot of time to advocate for healthcare interventions. We have worked with in East Texas with church brokers, if you call them that, religious brokers, to reach that community. I think one of the ways is to build a script with information that you can provide to them in very, we normally use, not that you're saying people are not able to understand complex information, but a lot of times we have, as professionals, use a lot of jargon. So I remember even for infant mortality, when I was doing intervention for that, I have to talk about babies dying before their first birthday, and low birth weight, babies being born too small, or small for gestational age, or too early. So you have to use language that is easily communicated to the congregants. And once you meet and get a buy-in from the church leadership, they will. A lot of times we have seen sites, and church sites can be set up as, even for healthcare fairs, where treatment is administered right on site. So I'm sure they're open to that type of collaboration with the healthcare system to reach the population.
Thank you. Thank you so much. During this segment, our poll asked, do you trust your healthcare provider? And 95% of our responders said, yes, they do. So that is some good news. And probably that alludes to your explanation that Black and brown physicians are actually going back home to provide care. Thank you, Dr. Barrett. And we're moving on to our third section. But before we do, Dr. Ibu has texted he is unable to join us because he's still tied up with that other issue from today. He sends his apologies, and he would like to meet with us for a podcast so he can share more about clinical investigations and building diversity and inclusion in not only as Blacks as participants, but also as Blacks being leaders of research and clinical investigations. For our third segment, we're moving into bridging the gap between trust and distrust. Our question for this segment is, have you experienced stigma in healthcare? Our first speaker, Ms. Yashika Roy. Her professional interests are in the treatment and management of patients living with HIV. She currently works as a nurse practitioner, run navigationally based chronic disease management clinic, along with 2 other nurse practitioners. Together, they manage patients with congestive heart failure, cerebrovascular accident, hypertension, diabetes, HIV, and Hep C. Yashika earned her Bachelor's of Science in Nursing from Lamar University in Beaumont in 2005. After becoming licensed as a registered nurse, she worked the cardiovascular intensive care unit for Christus St. Elizabeth Hospital. After about 18 months, she decided to transition to palliative care to serve patients and family members as they progress through the dying process. Finally, Yashika found her current place of employment at Baptist Hospitals of Southeast Texas. She began as a charge nurse on a telemetry unit, where she remained until the completion of her Master's of Science in Nursing in 2015. which she received from McNeese State University in Lake Charles, Louisiana. Maintaining her employment at Baptist Hospital, she transferred to the Chronic Disease Management Department, where she currently works. In the summer of 2019, Yashika was accepted into the Doctor of Nurse Practice program at Texas Tech University Health and Science Center in Lubbock, Texas. She is currently a full-time student in her program and plans to graduate in May 2021. She's a member of Antioch Missionary Baptist Church in Beaumont, Texas, and serves as a member of the medical ministry and a member of the G4 to 12 youth ministry. In her spare time, she enjoys spending time with the lights of her life, her 3 sons, Trey, Xavier, and Brandon. Welcome, Miss Roy.
Thank you. Thank you. I'm glad that you had me here. This is such a huge topic, in the Black and Brown community, of bridging the gap between us and the trust and the distrust in our Black and Brown community and the healthcare community. So I'm hoping that this last segment between myself and Dr. Osmond will kind of sum up everything that we've talked about tonight. There is a huge distrust in the healthcare system and our Black and Brown community, and it stems from a lot of different things. Our older population will talk about the Tuskegee experiment and how they fear that, but the younger population are scared of different things like stigmatization, being looked at differently, not being believed when they come in with a complaint of pain or some ailment going on. They have the fear of not being believed and trusted, and so they don't really trust our medical profession. As a nurse practitioner, having a little bit more time with my patients in the office, I spend the first few minutes of my sessions with my very new patients, trying to develop a rapport with them and trying to develop a relationship with them so that, we have that trust and they can understand me. And I can understand them, and they don't feel rushed. They don't feel judged. They open up, and I can get the information from them that I need and the way I can. So I wanted to share a personal story myself that I experienced as a patient. Like I said, I've been a nurse probably going on about 15 years. So I was a professional nurse at the time that this happened. So I was working for a facility, and I was pregnant. My son is now 11. So he's almost 11. So this is about 10 years ago. I was working for this facility, and I had my baby there at this facility. So I have my baby that day, and that night I moved from the labor and delivery department to postpartum. So the nurse that's taking care of me at the time, she's doing her thing, and I asked her, so when will they do the surgery before I leave, or will I have to bring him in later? Her response to me was, oh, you had to get that approved 30 days ahead of time. You should have had that approved already before your hospital admission. So I was confused. I was like, oh, okay, I didn't know. Let me talk to my doctor about that in the morning. So my doctor came through the next morning. She was an African-American physician, so we had a very good rapport with each other. We really got along, and so I talked to her, and I'm like, I'm trying to find out about his circumcision, and the nurse told me that I didn't apply 30 days ahead of time, and I didn't know. And she said, you don't have to do that. That's for Medicaid patients. You have commercial insurance. You don't have to do that. So this nurse, the prior night, automatically assumed, because I was a young Black female, that I was automatically a Medicaid patient. She didn't ask me about my insurance information. I'm assuming she didn't to look at my information in front of my chart. She just assumed that I was a Medicaid patient. During this same hospital stay, I developed some complications and had to stay a little bit longer in the hospital than I would have normally had to. And the management department will discharge my newborn home. And I didn't want to let him go. I'm a new mom, and I didn't want my baby to go home. And her response to me was, quote, where is your baby daddy? And I said, well, my husband is here and he's at home, but I don't want to discharge my baby home. I want to keep him here with me. Of course, I discussed that with my doctor again, and we got that taken care of. But there was another assumption at that time that because I'm a young Black female, I am a baby. I have a baby daddy. I can't be in a marital relationship. And it's a stereotype. They stereotype when they come in, and this puts a negative image of healthcare workers in the minds of our patients. So what message I want to send out to our patients here is to be informed, be educated, do your research, look up things. When you're going to the doctor, know your medicines, know your history, know as much information as when you go in so that you where your office visit goes. You can't always promise that, you're going to get a passion provider. And, I hate to say it, there are some vices in the medical healthcare, but it's not always like that. There's always a few bad in every healthcare practice, in every healthcare environment. So be educated, know what you're talking about, know as much as you can. Don't be afraid of the stigmatism. Go in, because the only way you can get help is if you go in and receive treatment. I take care of HIV patients, and stigmatization is huge in that population of patients because they're afraid of what people think about them or that people are going to judge them. So that's a huge barrier for them to get over. Dr. Barrett talked about, social determinants of health. That's also very huge in Black and brown communities. They have barriers. They have childcare barriers. They have transportation barriers. There's, social barriers. There's unemployment. There's socioeconomic barriers. There's so much that prevents us from being able to remain, diligent in our own health care. So just stay, forefront. And as we talked about these other patients, these older patients that may need help and assistance in COVID and trying to get COVID tested and trying to get COVID vaccinations. Like Dr. Barrett said again, please be proactive for these other patients out there that may need us to step up and help them out in our communities, maybe advocating to get to provide with them, help them get online and register for these vaccinations. And because our older population, sometimes they don't know how to work the internet. Sometimes they don't know how to get BeaumontHealthcare.com and register for their shots. So if we can go out and help them, we can all merge together. We can close that gap, and we can try to help our Black and brown community to progress and proceed and do better in healthcare. Any questions from anyone?
Thank you, Shika. There is still some chat going on. I assume your questions will be coming soon. I will now introduce
Okay.
Dr. Osman. And Dr. Osman, he's an alum of Meharry Medical College. He completed his internship at Baylor College of Medicine and his residency at Lincoln Medical and Mental Health Center in New York. He's a director of emergency medicine at Baptist Hospitals of Southeast Texas, here in Beaumont, where he is happily married and resides with his family. Dr. Osman serves on numerous committees throughout the region. He's also the medical director of a routine screening program, which began 10 years ago. He has been on the forefront of COVID and HIV detection in the emergency department. And because of his caring nature, his emergency department patients intentionally refer to him as their primary care provider. And he lovingly guides them to medical homes so they can achieve optimal healthcare outcomes. Ladies and gentlemen, please welcome Dr. Osman.
Hello and greetings all. I really, when Cordella asked me to join this panel, I kind of rolled my eyes initially, and I was like, oh, Cordella, I'm busy. I got to do this. I got to do that. But I am so glad that I joined this panel with Ms. Head Dr. Jackson, Dr. Barrett, and soon to be Dr. Roy. I am especially honored to be in a panel, albeit virtually, with Miss Lily Head. As a medical student and as a young immigrant learning about this country, I read about the Tuskegee experiment here and there, but to be in the same panel with Miss Lilyhead is really just quite honor for me. Uh, I have done thousands and thousands and thousands of informed consent, but from now on, every time I have to consent a family member for a procedure, Miss Lilyhead, your smiling, kind face is gonna come roaring into my head and just tattooed in there. So I will never forget that. I am not exaggerating, but if there really any hesitation is still remaining in the African American community or any community for that matter about the COVID vaccine, the little talk that Miss Lilyhead gave could have just been in a national commercial, and that would really just answer all the question or remove any doubt about any hesitation about the COVID vaccine. It is very touching to be in here. It's very touching to be with Miss Lilyhead, who's a descendant of the Tuskegee experiment. Again, like I said, you hear about it here, you read about it there, but to be on the same panel is really quite an honor. And I don't know who to talk to, but Miss Head, if you can do a national conversion, if there's any hesitation in the African American community or any community for that matter to take the COVID vaccine, please do. That would really work 100%. You really don't need any fancy production for that. What you said is quite illuminating. Personally, for me, I couldn't wait to get a COVID vaccine. I mean, I had reached a point with COVID. This is what, February 26th. We are in our 13 months of COVID in this area, I believe. I couldn't wait to get the COVID vaccine, and I think I heard it from other people. But I was ready to get the vaccine, to get a shot into my eyeball, if that's what it takes to get the vaccine, because I have put plenty of patients on the ventilator. I just did one. I'm in the emergency room. I'm hiding in the back in one of the administrative offices. And I just put somebody on the ventilator in one of the rooms. It is getting better, but hopefully this is not a false lull like it was recently. But when I got my vaccine, Beaumont, Texas is not, it's still a small town. There's TV stations, there's newspapers. And I tried to emulate the young nurse from New York who was of Jamaican descent, who was the first nurse who got COVID in New York, and I think she was in the front page of the New York Times and all the TV stations. So I was on the front page of our local papers and on TV along with my other colleagues, celebrating the arrival of the COVID vaccine. As far as access disparity, the panel in here has really way more expertise on discussing that more than I do. I am your friendly neighborhood emergency physician. My personal take is, I went to medical school, but I get my motto of how I work in the ER from the Hard Rock Cafe. If you ever been into Hard Rock Cafe and you look at their menu, underneath they have a line that says, love all, serve all. So that's the way I really do work. I am very cognizant of disparities in healthcare, the stereotypes, and the soon-to-be Dr. Roy has really, I mean, the real examples that you just gave, the dehumanizing, or it is not really the disrespect, let's just put it that way, that you have received it is not, it is unforgiven, and it is really not necessary. At the end of the day, I'm not Christian, but the saying that I usually use, that I've learned by being in this country for 30 plus years is, and I think Miss Lilyhead had alluded to it, we are all children of God. Uh, a Medicaid patient or no insurance patient or insured patient, commercial insurance, etc., we all really need to have the same treatment. This is not the place to talk about. We all need to really be respected and get the same treatment. Again, this is not the forum to talk about health insurance, but again, about disparity, access to vaccine, access to healthcare. I got stories until midnight to tell about an African American lady who come with the breast mass that is. You don't really. The ER is not the place to diagnose breast cancer, but I've seen African American patients who came in here with a breast mass that has been just growing and growing and growing and breaking the skin and fungating, and just you're looking at it and you can say this is cancer. This is the stuff that, if there was any access to healthcare, if there was any education, this could have been caught with a routine mammogram when it was tiny little small thing. I mean, so I get plenty of examples like that. Uh, so I would not go and rehash what the experts said as far as what causes disparities, the access to healthcare. Uh, Again, they have definitely have more experience than me. And just one more time, because I don't know if I will ever uh, be in a panel with Miss Lily Whitehead. That it is my personal honor to be in a panel with you, and I'm just going to brag about this forever and ever and ever. Thank you.
Thank you, Dr. Osmond. We have one question for you. Should people be scared of going to the ER for care in the midst of COVID?
Initially, people were scared, understandably. I mean, the people who worked in the ER were scared because we didn't know who had COVID. We didn't have proper PPE. So there's plenty of hesitation in the beginning of COVID. And that actually led to some people who stayed home because they didn't want to come and ended up with heart attacks and stroke that weren't treated appropriately and in a timely manner. So absolutely, yeah, that has happened in the beginning of COVID. Now we are into it. People should not. We have different part of the emergency room. We are getting better in our hospital. I'm very sure every other hospital have to triage patients to the correct place. So if you really have something serious that you think you have, as a heart attack, as stroke, don't stay at home. We had patients who would have otherwise came to the emergency room and get their acute heart attack taken care of in a timely manner that would have saved heart muscle, who stayed home for 3 days. Luckily, they were still alive, but there was serious damage to the heart that we would not have otherwise seen.
Thank you.
You will.
Ladies and gentlemen, Dr. Ibu was able to join us. We are so pleased to be able to bring him in. And Dr. Ibu is a clinical research specialist. He manages clinical trials by providing support to clinics and physicians in all specialties. Gadolin Research specializes in the management of industry-sponsored clinical trials and operates in the greater Houston, Pasadena, and Beaumont areas. His clinical trials include studies on COVID, Alzheimer's, and STIs. Dr. Ibu is an alum of Texas Tech and Ross University School of Medicine. He's a member of the Forensic Research Association of Meharry Medical College and is actively involved in addressing health disparities in Southeast Texas. Ladies and gentlemen, please help me welcome Dr. Joel Ibu.
Very generous of you.
Thank you. We don't have video at the moment, but we can hear you, Dr. Ibu.
Oh, thank you. Unfortunately, I'm able to turn on my camera at this time, but I'm honored and and happy to join the esteemed panel members and the esteemed audience. Can you hear me?
Yes, we can hear you.
Very good. Would you like to proceed, or would you want to go ahead?
Please go ahead. We can hear you.
Alrighty. So I guess first of all, I do my most sincere apologies for being late. It's not because I had to squeeze this in. It was just because of unforeseen circumstances. So I just want to apologize to that about that. As Cordella stated, really what I do is I'm quite involved in industry research. That is clinical trials, bringing new drugs to market. So my company, Gatling Research, we work with pharmaceutical companies on conducting phase 2, phase 3, and phase 4 clinical trials with the goal of providing data that will either prove the safety or efficacy of said investigational product. So that's what we do with regards to the company as a whole. We work currently working with some pharmaceutical companies on some very exciting trials. I think some of the information is public, so I can share. One of the examples is Eli Lilly's ongoing trial for the treatment of Alzheimer's, which is looking like a game changer in that arena. And so we're seeing some very exciting data from that study, as well as the ongoing Eli Lilly and VIR COVID antibody treatment studies, which have been proved to be disease-modifying agents as well. So it's been an interesting journey for us as a company, and also for Southeast Texas as a community.
Dr. Ibu, what are the barriers in getting people into clinical trials?
That's the number one barrier. That's a very good question. Number one barrier is awareness. People are not very aware of what a clinical trial is, how they would benefit from a clinical trial, if they would benefit from a clinical trial, if they qualify for a clinical trial, and also sometimes, and especially with regards to minorities, minorities tend to be skeptical about participating in clinical trials based on the historical context of how clinical trials started and all of the events that happened in the past. So it's a conglomerate of all of these forces that really make challenging to find patients for some studies.
Thank you. Now, I know that for many, when I first heard about the Tuskegee study, there were many people who did not wish to take the medications for Hep C, and there were some who refused to get tested for HIV because they actually thought, oh, they were going to get the actual disease. What are the benefits of having all demographics represented in clinical trials?
On multiple levels. It's the lack of representation of a diverse group of individuals from just different backgrounds in clinical trials continues to hurt everybody. Because what happens is the data we obtain as a clinical trial site is not representative of the population the drug is going to be used in. And therefore, we end up with more side effects. We end up with drugs that may not work for some groups and may work predominantly for groups who participated in the clinical trials. And so it's a catch-22. There's a general distrust in, especially minorities, based on historic, and I would say, from my perspective, justifiable distrust in research, but at the same time, the lack of participation.
Did we lose you, Dr. Ibu? Did we lose Dr. Ibu? Oh, I am so sorry about that. I hope you'll be able to rejoin us. While we await his return, we do have our list of resources for all the participants on this program. And I would like to thank you all for joining. There is a question was posed in the chat regarding people who are living with HIV who are skeptical about taking the COVID vaccine. Is there anyone who would like to respond to that and how we can have patients more, somehow more agreeable to taking the COVID vaccine?
I don't know. Was that question for me? I just saw myself being placed in queue. I don't know that. Yeah.
I didn't direct it to anyone in particular. I just wanted to know if there was anybody who would like to accept that question.
Could you repeat the question?
The viewer said there are people who are living with HIV who are skeptical about taking the COVID vaccine, and they wanted some clarity on ensuring or having you answer, the panel answer their question, their skepticism about taking the vaccine with an HIV diagnosis.
I think maybe one of the clinicians should answer that question. I don't know the challenges when you have comorbidities in terms of vaccine, especially for the COVID vaccine. So I would just step back because I'm a doctor, but not that doctor at all. So I won't even pretend to know the clinical aspect of that question.
Okay, soon to be Dr. Roy, would you like to answer that question?
So when I'm speaking to my patients about the COVID vaccine, I explain to them that we want them to have a healthy immune system because we want that vaccine to have the appropriate immune response. So we really don't promote any vaccinations when their C4 count or their immune system below 200. We don't advise any vaccinations, but HIV patient with a very healthy immune system, CD4 count of at least 400 or better, we do tell them, that we encourage them to get the vaccine if they have the opportunity to get it.
Thank you. And I know that Dr. Osman has disclosed that he took the vaccine. He was in the newspaper. He was on the Facebook page. Miss Lily has disclosed that she's taken the vaccine. Is there anybody else on the panel who has taken the vaccine?
I've taken both vaccines. I've gotten my second one the week before the freeze, and I've gotten both of them. I did really well with them. I didn't have any side effects. There are a lot of reported side effects that people were saying, but I did really well with it. A little arm soreness, but other than that, I did really well.
Great. I took both vaccines and I did very well. Also, so did my mom, who's in her 70s, and she did very well. And we do understand that there are others who are still waiting because of the registration process and how things are moving in respective states. So we're not putting anyone on the spot. There's a question from Kimberly, and she asked, what can healthcare workers do to change the things that Ms. Shika mentioned? And I think Dr. Osman alluded to it when he referred to Hard Rock. Love all, serve all. Does that sum it up?
Yes, it really
I
does.
the question is what should what, go ahead, Ishik.
I was just saying, I don't when I take care of a patient, I don't see anything but my patient. I don't see the color of their skin. I don't see their bank account. I don't see anything. We have to treat our patients as a person, as a patient, and not as a socioeconomic entity, as a race, as a whatever. We have to treat our patients as patients for what they are there for and for whatever service they need from us.
I
Thank
agree
you.
with you, Sheikh. There's really nothing more to add except to really just re-emphasize and have empathy towards your patient, regardless of their skin color, and spend as much time as you can to educate the patient. So, absolutely. But love all, serve all.
Thank you. I actually love that. I love that. Dr. Ibu is back. If you do have any other questions for him, here he is, live and in living color. It's good to
Yes.
see you.
Good to see you, Cordell.
It's good to see you. And Robert mentioned regarding serving patients, start out always with an open mind and an open heart. And I think that helps us to go a long way, because we then realize that we're more alike than we are different. And Dr. Ibu, regarding clinical research, and as we were talking about having people from different demographics participate, I think that's where we lost you. Because one of the issues with our people in the Black community, there is actually a distrust that we really have to validate. However, we cannot sit on the sidelines and have medicine be prepared for us without us being included. How would you suggest that we break that barrier to get more people of African descent or Black and Brown people included in clinical research, and not just as participants? We want them as clinicians as well as researchers.
That's Cordetta. The question is it's kind of the answer itself. That's the only solution, because without having more minority researchers, we're not going to be able to increase minority participation in clinical research. I know you and I talked before. I gave you the example of a patient of mine in one of our studies, where I tried to encourage the patients to participate in the study. She was African American, and I wasn't her provider, but she really didn't. I explained the study, the risk and the benefits, but she really wasn't convinced because just the word research will turn people off. And it wasn't until her provider, who was also African American, stepped in, and she trusted him. She had that relationship with him, and she was willing to participate. It's a situation where people need to be able to trust the process because of the historical context of all the things that have happened in Tuskegee, all the things that happened that were brought out in the Nuremberg trial, all the things, all like the story Henrietta Lacks, for example. All of these things historically has led to a distrust in research. But we can't let, as minorities, we can't really let that get in our way. We have to participate so that the data we're represented within the data that's collected and dissected to see if the drug works or doesn't work. Otherwise, it will be is equivalent to letting other people, so to speak for us, and which we don't want to do. I'm sorry, Cordella, I think you're muted.
Kimberly asked, she says, the research process is so difficult for those wanting to do it. How can facilities make it easier for those interested in performing research?
Sorry, I laugh because yeah, I really agree with you. The research process is difficult. Part of the reason it's difficult is because there's this cyclical thinking. They don't, especially industry-sponsored research, they wouldn't really want you to participate in research unless you have research experience. You can't have research experience unless you participate in research. So that's the first obstacle that you're going to find when trying to participate in research. The second obstacle you're going to find is that it's a different beast of its own. It's not clinic. It's a lot more detailed. It's a lot more specific. It is governed by a different set of regulations, ICH GCP, which kind of stares back to the other question, which I'll touch on, kind of the answer to the original question, the first question. But to answer your question more directly, it's really training and understanding of the process, having someone be either your mentor or have somebody come in and walk you through the process. And I will tell you, I have done this 5 times. I have started out, I guess my own research site will be 6. It's not hard to do. It's just understanding what to do, understanding where the resources are and having somebody that's willing to explain it to you. So it's very doable. If you would like my assistance, please reach out to Cordella. She can provide my contact information. I'll be more than willing to have conversations about this. I do it for free anyways. But to circle back to the other question, Cordella, yes, there's been historical, I guess discrimination is not really all encompassing, but there's been issues with research and minorities in the past. But what has happened recently, and the way the research industry has evolved, should be of comfort. And the reason is, I'll give you an example. I'm originally from Nigeria, and we can't do industry-sponsored research in Nigeria because we have not adopted the international guidelines or safeguards to conduct research today. So if we don't adopt those guidelines or safeguards, you would not be permitted to conduct the research. Then the US, obviously, US has adopted it, and so that's why we're able to do industry-sponsored research here. Those guidelines and safeguards require informed consent before of all patients prior to starting any clinical research process. So the patients are dutifully informed of all aspects of the study, the risk and the benefits of the study, so that they are aware what happens to them, what happens to their bodies, what happens to their samples, and they agree to those processes. Patients also have to agree to any amendments in the research while it's ongoing. And so if the pharmaceutical companies decide that, you know what, we want to collect one more tube of blood, for example, patients have to sign off and agree to that extra tube of blood being collected prior to continuing in the study. So there are quite a few safeguards as well. Also, safety concerns. If there are any safety concerns that are found while the study is ongoing, the patients have to be aware of those safety concerns, and they have to have the option to decide if they choose to continue in the study or not. And I would say one more thing about research, in hopes that I'm not hogging all the airtime. Patients get exponentially better care when they participate in research. It's just simple and short. This is just the pure truth. I'm not saying this because this is exclusively what I do. It's just the truth. I'll give you an example. The monoclonal antibodies that have been approved by emergency use authorization for treatment of COVID. If somebody unfortunately has COVID and they qualify to receive that antibody treatment, they would go to the facility, get the infusion, and then go home. The PCP will order that, put in that order, and the patient will go home and hopefully feel better. But if that patient was getting that same treatment through a research study, like the one we're conducting, that same patient will get 8 home visits. We will draw blood every time. We will make sure that every lab is checked and that none of the discrepancies that we observe in the lab are, is going to put the patient at harm. If the patient has any safety concerns, they'll be brought in, they'll be seen by the principal investigator. And if they suffer any medical adverse events as a direct result of the research, all of that care is taken care of. The cost of the care is taken care of by the pharmaceutical company. So it's better care while you're in research, and you have access to cutting-edge medication. And a lot of the safety concerns have been a lot of guardrails have been put to address some of the safety concerns that we've discussed.
Thank you. Kimberly asked, what advice do you have for patients who would like to participate in research?
Very good question. The number one thing is the informed consent form is my number one advice. Make sure you get your copy, make sure you keep your copy, and make sure you read it. Because a lot of times what we find is some sites, some research sites, and this is always an FDA finding, do not do a good enough job explaining what's in that consent form, and some patients aren't curious enough to read it. And so really that's the number one thing. Be aware of all the pros and cons of entering the study so you know what you're expecting when you get into the study. That's my number one advice for anybody participating in any research study. Always keep your consent form, read your consent form so you're aware of what you're getting into.
Thank you. Dr. Barrett would like to share some information on non-clinical research.
So I just wanted to give a plug for non-clinical because I see health and healthcare work hand in hand, and usually the promotion for better medical care. So before you actually need medical care, some of the interventions that public health does is so critical. And so what some of the research, a lot of times people can enter the research arena by choosing to participate in fellowship. So somebody had asked about how do we get into research. I know at some bachelor's level, they're offering, a lot of universities are offering fellowship. And I just can talk about my daughter signed up with a university to do research. And she's a second year bachelor's level student. And so she's already being exposed to to conduct research, and at 18 years old, I mean, going 19, that is. But there's a lot of way to enter into the research arena and get an experience before. A lot of time people think you have to have an MD or a PhD to get into research, but if you start early and interested in participating, and I think that's how we can build that Black and brown researchers, and think that there are different aspects. So if you're not pursuing a degree, a clinical degree, and there's sociology type research, there is public health research, and there's other non-clinical research that will feed into clinical research, knowing about the social determinants of that patient, so that you can prepare clinical researchers to have a better understanding of the population that they're going to work with. So I just shamelessly giving a plug for our public health.
Thank you. Thank you. That's very valuable. Ms. Lily has a question. Okay.
Good evening, Dr. Ibu. It's nice to see you, and so happy to hear that you are speaking about clinical research. I have a question, and perhaps you can. I hope that you will be able to answer it. Is there any clinical trials or research being done that one could get involved in on dementia or Alzheimer's disease, especially amongst the African American people and the men particularly?
Yes. Very timely question. Eli, this is a shameless plug because I am, maybe not so shameless. I'm hoping to participate in the study, and most likely I will. I'll find out next week. But Eli Lilly has a game-changing drug that is in phase 3 right now. Unfortunately, I can't tell you the name of the study because I'm still in process. We're still in the process of the study startup, and so I can't release the name. But it should be public actually. They have a very exciting investigational product that is looking. It looks like it is most likely going to be a very strong candidate to reverse some of the impact of Alzheimer's, which is truly, truly mind-blowing. And so I would suggest that if anybody's looking to participate in a dementia trial, they Google Eli Lilly's upcoming study. The drug name is donanemab, I believe. And so if you look that up, you should be able to find a location, hopefully around you, where you can participate in the study. It's really supposed to be a game changer, and the results is just impressive. Now you have to understand the scope and the landscape of Alzheimer's research. For the past probably 4 or 5 years, every drug for every pharmaceutical company has failed. Every new drug has failed. There are multiple companies who had spent billions of dollars, or at least millions of dollars, trying to find an investigational product or a drug that would at least modify the disease. And this is the only one that is proven to, not proven, I apologize, it's not proven, it's in research, that seems to do so based on the preliminary data that they have released that is public.
Thank you.
You're welcome.
Dr. Ibu, Dr. Jackson has questions for you, and she had comments about the consent for clinical trial.
Yes. Sorry, Dr. Jackson, you're muted.
Mine isn't really a question, it's a comment. In the research that I've done, I've come to realize that it's important to not just give the consent form to a person, but to actually go over it with a person, but more importantly, to write it in language that can be understood. And I've also learned through my research that a considerable number of people are only functionally literate. So it's important, again, to go over it with them and not ask them to read it, because you may be putting them in an embarrassing spot. But if you lead the consent form discussion, it takes away any problems there. And the second thing is, one of the things that descendants are trying to do is to change the paradigm of responsibility. And we refer to the study as the United States Public Health Service syphilis study, not the Tuskegee study, not the Tuskegee experiment. The blame was for the Public Health Service. When you say Tuskegee study, it sounds like it is Tuskegee that was responsible for the study, and it wasn't. So those are only 2 comments that I wanted to add to your presentation.
Thank you.
Thank you. It was an excellent presentation, Dr. Ibu.
Oh, thank you. Dr. Jackson, if I may just follow up with what you said. What you said is the lifeblood of getting a patient into a study, especially minority patients. So, in fact, I was a sub-investigator on a study at my research center, and it was the very first in human maternal vaccination study. So imagine this: we were vaccinating pregnant women for RSV, against RSV for the first time. Mm-hmm. And my site was one of the highest enrolling sites in the nation. This was in 2017, 16 and 17. And that was because I insisted that we come up with a way to explain in very lay terms the pathophysiology of what we're doing to the patients. If not, there is no way you're going to get a pregnant woman to take a research vaccine when you can't tell that somebody else has done it and it's fine. So we had to really work on the language. Like you said, we had to make sure that the language outside of the consent form, we had to even make it more plain and literally paint word pictures in a way people would understand. And that was why we're very successful with enrollment in that study. So you absolutely hit the nail on the head.
Well, thank you. Because in my years of experience of doing interviewing, that's one thing I've learned. You have to realize not everybody knows the jargon of whatever your profession is. And it's really important to get it explained.
Thank you. And while we're coming to the end of our program, Dr. Barrett has a question for Dr. Ibu. She asks, can you speak to the side effects of drugs during clinical trials? For those who are watching online, if you have any other questions, could you please post them so that we may get them to our panelists as quickly as possible? Thank you.
Yes, with regard to side effects, that's what research is for. That's what we're trying to find out, what those side effects are. If we understand if I guess a clear picture of the process of research, they go through preclinical developments and animal studies before they test them in humans. So some side effects are caught early, like in the animal models. And so in fact, there's been instances where the FDA has insisted that the label of the drug have a side effect that was found in an animal model, and then through phase 2 and phase 3 of the clinical research study, that's what we're trying to investigate. Phase 2 is typically about safety. Is it safe? And then phase 3 is about efficacy. Does it work? And there's overlap all over. We're always looking at safety and efficacy, but those are the primary reasons why we conduct the phase 2 and phase 3 studies. And so with regards to the side effects, the known side effects are always listed in the informed consent form. However, there's also a process called an SAE, or severe adverse event reporting. There are some side effects that are categorized as SAEs. Those are immediately reported within 24 hours to the research sponsors, so they can report to the FDA. And if the doctor, the principal investigator, decides that the study or the drug is not safe based on observed side effects, they also have the authority, without asking any of the pharmaceutical companies, you have the authority to stop that study at your site. You have the authority to withdraw the patient for safety reasons. And so we're constantly looking for actively surveilling patients for side effects with the goal of trying to identify them and report them in aggregate. And you also have to remember that this is going on in perhaps 50 to 80 locations of clinical research sites all at once. And so that's all getting aggregated to a board called the Data Safety Management Board, DSMB. And they're looking at all the data in real time to see if the same side effect observed in my clinic was observed in other clinics. So we know if this is something that we need to shut down, or if it's a study that we need to continue, or if it works. They look at the data from time to time to see if it works. Because if the drug isn't working in the middle of a study, then there's no point exposing patients to the risk.
And the reason I ask, because a lot of people are concerned about the COVID vaccine, that, clinical trials are much longer. And because of the urgency of the vaccine, a lot of people were saying, did they actually test it thoroughly to know that it won't bring about certain side effects that were not considered during our more rushed an enhanced type of clinical trial. And that might be some of the reasons why people are a bit reluctant to take the vaccine. So I just wanted, and thank you for that. That is something that I did clinical epidemiology, and so we had to go through clinical trial and understand the whole context. But I'm glad that you're able for our listeners to explain that process and to say, oh, those issues are as much as possible were alleviated during the clinical trials.
Oh, thank you. If
Thank
I
you
may
for
just
that response.
a quick comment about the COVID vaccine and why, at least with Pfizer and Moderna vaccine, why I have a level of comfort with those vaccines. I do have the concern that people share that they haven't been studied. There's no long-term safety or efficacy safety studies on those vaccines. But the technology and the science behind it, I'm not sure if it's been discussed, because it's pretty exciting science what you're doing. Then typically a vaccine is a challenge to your immune system. So we take something that looks like the virus and challenge your immune system. The problem with that is it could also trigger other, that whatever we put in your body could also look like something else, and it could cause other side effects unintended. With the Pfizer and Moderna vaccines, those are mRNA vaccines. So they go, when they absorb into the body, the body makes basically parts that look like the virus, but not the virus itself. And your body responds naturally as it would if you had COVID anyways. So if the concern is with the side effect of the vaccine, well, we are all at risk right now. As I told my staff, we're all in a global clinical trial, if we like to, without any informed consent or anything, because it's either you get a vaccine or you risk getting COVID, or you get placebo, which is you do nothing. But we're all going to participate one way or the other.
Yes, and that is great. Thank you so much for touching on that mRNA vaccine that is new to us in healthcare, and I think it's going to be a game changer with how we look at preventing disease. Thank you so much. So far, there was just one more question, and it was in regards to being concerned about the COVID vaccine trial not having enough members of the Black and brown populations. It says, Dr. Ibu, were you involved with COVID vaccine in getting Black and brown participants?
I was not involved in the COVID vaccines trial. What I've my niche is maternal vaccination, and so we're hoping we'll join the Pfizer maternal vaccine COVID vaccine study. But though I do have colleagues who were, and it's the same issues, issues of just distrust in the healthcare system and distrust in clinical research. So there's serious underrepresentation of minorities in these trials, and the outcome is going to be the same long term if that's not corrected. It's interesting to note that pharmaceutical companies are very aware of this and they're actively trying to do so, but it's a different conversation for a different day why those efforts, in my opinion, have been ineffective.
Right. Okay, and the last question is, can you get COVID after taking the vaccine?
Is that me?
Yes.
The answer is yes. And I have to say yes because, in fact, I think there was a recent study published that stated I can't remember if it was 70% reduction in transmission, but you can get the vaccine. You can get COVID, but it may be harder for you to transmit because your viral load is a lot lower. I have seen come across my clinic verified individuals who have gotten COVID multiple times. At least, let me rephrase that, please. A positive COVID test multiple times. And I have not seen anyone who has had a vaccine or has been vaccinated and had COVID, but it can happen. And primarily because of the different strains that seem to be evading the vaccine and evading the antibody treatments. Because of that, the COVID that the vaccine was made for may not be the COVID that you catch, and so it's very possible. So that's why moral of the story, wear a mask regardless. You get vaccinated, wear a mask. If you choose not to get the vaccine, wear 2 masks.
Okay. Thank you so much, Dr. Ibu. This has been extremely enlightening, and I'm looking forward to sitting down and talking with you soon.
Same here.
There's so much more to discuss. Would you like us to share your contact information, or how?
Yes, you can share my you can share my Gatlin Research email, and whomever wants to reach out to me, please do.
Okay, thank you.
Thank you.
Ladies and gentlemen, this has been extremely enlightening. It has been refreshing. It has been educational. I am honored to be in the presence of our esteemed panelists. I've learned so much. We've all learned so much. And more than anything else, it's looking at the unity and knowing that we're stretched across the United States in doing God's work. We're all touching lives in our corners, wherever we are, but thank God for the digital space. We're able to, sit in our living rooms and touch each other and provide much needed education in these uncertain times. I want to thank you all for participating, sharing your subject matter expertise, being patient. And I'd also like to thank our guests for tuning in. The discussion has been recorded, and the link will be available to you, and that you may share or you may keep, do as you choose. I will be in touch with you, because now that we're family, I will be calling in and checking in. And I've also shared the contact information with the panelists regarding your bios. And hopefully you'll be able to get in touch with each other if you should need each other's expertise along the way. I appreciate you all. Thank you so much. And I'd like to give us a special thank you again to our supporters, 310, Mr. Rudy in New York. I met Mr. Rudy. We went to the same high school, and we were planning a different event, and I heard his voice and I said, oh, maybe you could help me. And here we are doing our second event. Of course, Baptist Hospital of Southeast Texas, we're here to serve the community. And we do whatever it takes to meet our patients wherever they are. Achieving Together is the state's plan, the state of Texas's plan to end HIV. We're the only southern state, or the first southern state with a plan to end HIV. ANAC, our Houston Gulf Coast chapter, we do so much. Our nurses are out there. Some of us are on the front lines of COVID and HIV at the same time. And of course, Voices for Our Father's Legacy. I don't think we'd be in the space without Miss Lily. I was so thrilled when I sent that email and she responded, and now we're family. I'm looking forward to all the great work they will do, and I'm also looking forward to visiting and learning more about the legacy of our forefathers. Thank you so much. Thank you for joining, and you may contact me here at Baptist Hospital should you need any more information on this topic. Good night and be well.